Okay, welcome back, everyone. I hope you enjoyed your lunchtime conversations and had insightful discussions during your breakouts. It is my pleasure to introduce our moderator for this report out session, Tina Shah. Dr. Tina Shah, who is Medical Director of Practice Improvement at WellStar Health System. Welcome, Tina.
I'll take applause anytime I can get it. So let's take a step back. We formed this collaborative in 2017, and we had this idea that there is a huge problem happening in our world of medicine. And then we thought, hey, we really need to pull together what we think is going to be a sentinel report building off of To Err is Human and Crossing the Quality Chasm. And so we pulled together this team that was here to really develop the consensus report. And then the report came out. And so here we are. And the question is, now what? Right? But this is really the moment where the rubber hits the road. And this group discussion is really targeted on, okay, so we have these different recommendations, but now how do we process it, talk about it, bring it home, and really shift the culture, the infrastructure, and make it a place where we can now say in a few years, not in decades, that healthcare truly is better. So I just want us all to kind of think that over. For me, I think there's two things. One, at the end of this session, we should all have a good understanding beyond reading the report of all of the 6 recommendations. So our purpose here is really for kind of sharing information across the 6 different recommendations and the discussions we've had so far. But there's a second thing, and it's really bringing this home. And so I'm actually going to give everyone homework because you're listening to me right now. And here's the homework. Think about 3 things by the end of this discussion that you're going to take home. And if I may be so bold, and if you happen to be on Twitter, I want you to actually put it up on Twitter and put the hashtag clinician wellbeing and also put NAM's name on it so that we all can hold each other accountable and also see what really resonated with folks. All right. So with that in mind, what we're going to do in this session is actually have report outs from our leaders from all of the 6 groups, and then we'll actually have a discussion, and the aim would be for the folks listening in and for folks in the room to really ask questions to foster discussion with that goal in mind. How are we going to take this home, and how are we going to actually execute on all of the wonderful recommendations that have been developed? So let me first introduce Chris Sinsky, who's our Vice President of the American Medical Association.
Thanks, Tina. So my pleasure to report out on our group. We have 3 pages of... Sorry, my pleasure. Now you might be able to hear me. We had 3 pages of really great ideas, and that didn't even surface all the ideas that were present in the room. And I'm just going to give you a few highlights. So our task was to talk about how to improve, to create positive work environments. So that's my day job, right? So that's it was great to listen to all these ideas. And we looked at it under the subcategories of measurement, workflows, and infrastructures within an organization. And we asked people to identify bright spots and then to identify strategies to overcome any barriers to implementing that kind of a bright spot in another organization. So a couple of notes from each of those. The first, under measurement, one of I think the most important things that was mentioned was measuring for what purpose? Because nothing will drive cynicism more than having physicians being measured and measured and measured and feel like it never comes to anything. So I think it's really important to be clear about the purpose of the measurement and then what you're going to do with that measurement afterward. And so we identified that one of the purposes is to have insight into what's going on in your organization so that you can open up the conversation with key stakeholders to develop interventions that will drive change. So we're not just measuring to measure, we're measuring to drive change. And also, by doing measurement, we have the opportunity to develop shared accountability so that leaders at multiple levels within the organization can share accountability for the well-being of the entire workforce. so that the chief wellness officer is not the only one responsible for those scores, but actually the CMIO and the CIO might be sharing in responsibility for the well-being scores, and then that translates into a different kind of decision-making when it comes to some aspect of technology. Same thing with compliance and that sort of thing. So we also talked about workflows, and when we were talking about workflows and surfacing some bright ideas, and one of the bright ideas that people brought forth was team documentation, where the task of recording whatever needed to be recorded for the visit note or the daily hospital note was shared among multiple different professionals as opposed to being up to just the physician or the APP. And so when we think about, well, how do we implement that, we want to answer the question, what's in it for me? For our bosses, for those who are above us, if you will, in the chain, and also for others within, so maybe for those who report to us. We can't just have a good idea without asking, how does this improve my teammates' ability to have a good work environment? How does it improve my boss's ability to meet their objectives? And then our third area was thinking about infrastructures. What are the organizational infrastructures that create the conditions where clinician well-being is more likely to occur? And with that, we were thinking of a number of things. One was that concept of shared accountability for well-being up and down the leadership chain, if you will, and across many domains of leadership. Another was when hiring a position with responsibility over well-being, that it not be a checkbox, that you didn't just check the box that we've hired a chief wellness officer, we've hired a chief diversity officer, but that the location of that person within the organization really will impact the efficacy that person has in getting their work done. So that person needs to have the resources, the partnership, the authority, the influence, the location within the organization to be impactful. If you are a wellness champion buried down low within your organization, you'll have different impact than if you're the chief wellness officer who reports directly to the CEO or reports directly to the board. And then as a bright spot on infrastructure, this is something that was talked about slightly after our whole group discussion, but I think was powerful enough to share, and that is Dr. Schoenefeld shared that at Stanford they've been able to engage an entire infrastructure that was already in place for transformation. So a change management infrastructure that was already in place, a quality improvement infrastructure, and create dyads between a quality improvement expert and a well-being director at all different departments and all different levels throughout the organization. And Tate, I apologize if I'm misrepresenting that, but that was $30 million worth of resources that could be used to support well-being because it was already there in existence and created, and that dyadic relationship allowed more impact. I think I'll stop there, and we'll look forward to questions and comments and other thoughts from our group during the discussion.
Thank you for that. And now I'll just go ahead and introduce Lois Nora. She is the Professor of Neurology, President Emeritus, and Dean of Medicine Emeritus of Northeast Ohio Medical University.
Good afternoon. I had the privilege of listening to and trying to summarize the group focusing on the learning environment. The Learning Environment group looked at the recommendations, which are initiatives to improve, initiatives to assess, and convening broad groups of interested parties, accreditors, and others to focus on learning, the learning environment. The group looked at it in terms of barriers, what exists out there to galvanize support, what would they prioritize, and what can the National Academy and the Collaborative in particular do at this point. We've talked a lot about barriers today. I'm not going to review them, but certainly there was discussion about cultural divides, failures to see the link between the learning environment and the practice environment. And really, there was a fair amount of discussion about how we really have to understand them as intrinsically linked with each other. power differential that may be particularly unique in the learning environment, and economics. How do you do educational value in an RVU world? So I anticipate we may talk more about some of those barriers in the discussion. But there are things that galvanize support, and things that were mentioned include the research that needs to be done to result in the practical suggestions that people can implement so that they have a roadmap ahead of them. Mechanisms to help our cultures understand individual success within the broader context of group success and team success. Seeing attention to the learning environment as being a key aspect of mission-based leadership, not just leadership in a silo, but leadership of an area that should cross the entire and influence the entire institution. Other things that can galvanize support are existing tools, linking into accreditation standards, clear processes, and the like. Even recognizing that while they may not be the end-all or have all the answers, there are tools there that can be used. So practical suggestions. When the group talked about what would they prioritize now, one of the most important things that came out was we truly need to have a better global understanding of what the learning environment is, or what an optimal learning culture is. It was articulated so the learning environment has 2A, 2B, 2C, and someone said maybe it needs 2.0, which is the definition of what we mean by learning environment and learning culture. And to gain understanding and agreement across silos, across the continuum of medical education, across accrediting bodies and the like, as to what we mean by the learning environment and what the characteristics of an optimal learning environment and an optimal team for an optimal learning environment would be. Another thing that people would prioritize is to really focus on understanding the work of enhancing learner well-being and the learning environment within the larger context of leadership in our academic health centers, in hospitals, health systems, and the like, linking the learning environment to the mission, and defining the impact of the learning environment on the economics and the mission of the institution, not only in terms of extrinsic, but also in terms of the intrinsic motivation of the people that are there. So what can the collaborative do next at this important junction? How should the national academies be thinking about this? I think words that were used were, first of all, build on what is out there. We don't need to reinvent the wheel. There are a lot of wheels out there. We just need to get them on the bus in the right places and move things along. Integration. This concept of integrating the learning environment and the practice environment, teaching and practice and what that means. Being expansive. Take us out of the silos that we bring into this room. This collaborative has done that extremely well thus far, but how do we really engender more systems thinking among us, looking at other areas of work outside healthcare that may be able to inform us in terms of what we should be doing, and how do we reach out to new interested parties who may not have been involved in the collaborative as broadly as they could have been to date, and bring them in. To continue to champion culture change. We noted that the National Academies has this unbelievable convening authority and reputational influence. And so their focus on these priority areas, on the integration, on culture change, on understanding the issue, can be tremendously influential. And finally, within that convening authority, for the national academies to bring together the folks that have the tools, that have the ideas, that are doing the research, and make sure that they are helping to spread it as widely as we need to spread it through the environment in general. I'm sure others in the room will have additional to say during our discussion period, and thank them for the privilege of summarizing this for you now.
Thank you, Lois. Now let's go ahead and move on to Neil Busis, who is a leader at UPMC, among which he holds the roles of Director of Community Neurology and General Teleneurology Program. He is a clinical professor of neurology at the School of Medicine and is the Chief of Neuro and Director of the Neurodiagnostics Lab at UPMC Shadyside.
Thanks, Tina. So we were asked to talk about reducing administrative burden. And the discussion went in a lot of different directions, which I hope to summarize adequately here. And if some of the members have additional points, please bring them out in the discussion period. So the first question for our group was different than the other ones, which is reflect on recommendation for reducing administrative burden resulting from laws, regulations, and policies. How do you prioritize them? And the other three were basically the same: barriers, what's needed to galvanize support, and what can the Action Collaborative do. Although the priority for administrative burden to decrease was thought to be coding and billing, the discussion was actually much more nuanced, because the group said that we have to understand trade-offs and competing interests in an organization before prioritization. So all priorities are local. And one part of the consensus report, which we didn't mention explicitly this morning, which is really important for this discussion, was that healthcare organizations, the second circle, mediate the rules propagated by the external environment before they get to the front line. And there was a wonderful study from the IHI that said only 22% of programs, standards that people wanted to eliminate were actually national standards. Many of them are promulgated at the level of the organization. So this was a revelation. And one could go to one's organization now, reduce certain unnecessary things without increasing costs, in fact, probably saving costs and increasing efficiency. So we talked about priorities being local and understanding clarity on where rules come from and how they can be modified before prioritization. The barriers are somewhat similar to what's been brought up in the discussion so far. Lack of trust. Physicians sometimes feel that the organizations that make regulations don't trust them to do the right thing. There's lack of alignment. There's tension when policies are pushed down to frontline clinicians from external bodies. There are misaligned incentives. There's silos and fragmentation. And skipping ahead, this is why the systems approach is so important, because everyone thinks that their regulations are important, and no one wants to give up their regulations. Everyone did them with good intentions for their own particular statement of task, but when you're talking about the entire system, there has to be some give and take. And so that's why the systems approach is so important. And with that, silos and fragmentation, there are different perceptions of burden. What may be burdensome to me may not be burdensome to you. When we talked about what's needed to galvanize support and move toward implementation, one of the biggest things is to align the external environment with HCOs. Transparency about why and how, and the local interpretation of rules. We have to remove misaligned incentives. There should be accountability. We talked about feedback loops. The Joint Commission has a nice feedback loop which could perhaps be better publicized. So it's not only good to have a feedback loop, but you have to make it available and publicly easy to use and known to all. So there may be some things hiding in plain sight that are already out there that we don't have to reinvent, just as you said, put the wheels in the right place. They're already there. Measure what matters. And ultimately it comes back to George's keynote. the way to resolve a lot of these issues is to focus on the patient. Decide if we really value patient care, that's the way to get around some of these barriers and align things. Is that if you focus on the patient, what's best for patient care, that should be the North Star. And when we said, how can the Clinician Wellbeing Collaborative facilitate the implementation of these recommendations, this is, in its own way, the most important question among, I think, 5 of the 6 groups, because this is the first time that I'm aware of that there's been an NAM consensus report that has an action collaborative at both ends of it. So we are in a unique position to disseminate and implement this. So the NAM is a neutral convener. This is a great way to get groups together, as we have been doing for the last 2.5 years, to talk about things, perhaps to align their values, incentives, etc. I think the new thing that comes out of the consensus report is teaching the systems approach and how to implement it. Because basically all of these discussions about administrative burden was all about a lack of a systems approach. It was all about that. That's really, if you're going to sum it up in one thing, it's about a systems approach. People wanted specific examples, best practices, and case studies. And someone made a great statement. You know, we already have commitment statements out there. But they said, how about if we update the commitment statements rather than sort of general, apple pie and motherhood, to reflect the report recommendations, to have the people say, I'm going to follow these. So that's what we thought. Thank you very much.
Thank you, Neil. Next, let me introduce Alexander Ommaya, who's the Senior Director at the WAMC.
So our group started the discussion talking about some of the new developments, for example, digital assistants. And digital assistants are still sort of, you think of Siri as a digital assistant, but within the medical environment, still in development. And so things which could pre-populate some of the structured data that is needed for quality reporting or other purposes. And we also talked about, using the cloud. So specialty societies are using the cloud, in fact, what they call the deep cloud, to store information about knowledge artifacts that can be pulled down by clinicians in a variety of settings. So that was exciting too. But the barrier related to that was really understanding the data needed at the site of care. So the patient-centered health information, what is that? What are the required elements? And what are the standards around that? And of course, the standards are variable depending on the elements you're thinking about. So the thinking was, how can we use the Action Collaborative to sort of begin those discussions? We need to sort of engage with the folks who are interested in standards like the National Library of Medicine and ONC. But I think that would be a good starting point on that issue for the Action Collaborative. The other point we laid out was thinking about the research to understand technology use in the clinical environment. So there is some, but it's variable. A lot of it is developed by the folks who are developing the technology, as opposed to publicly oriented, well-designed research. So we need to think about a receptor site for that research. So understanding technology in the clinical environment. We also need to understand the patient-centered or patient-facing clinical tools and how those currently are deployed and understanding. And so that type of information could be identified by the Action Collaborative. What are those tools? How are they being used? And what are the areas needed for further development? And that would align with the need for standards and data requirements related to that. We also thought about the technology innovation group that could bring together folks in the private sector and folks working in our various health institutions to think about both the development pathways, but also the opportunities as it relates to standards and definitions as well. So I'm just trying to see if I left any of our recommendations out. One other one is thinking about human-centered design, capacity building, and also tools for human-centered design. So what are the use cases, the guidelines, the expertise needed at the institutional level to sort of incorporate these challenges within or utilize this resource within healthcare institutions? And there was one other final thing, and it relates to sort of understanding the business case for purchasing of these new tools. Could there be additional business cases or tools related to the business case that could be valuable? So you could think about not just within technology, but how would you calculate the cost of pajama time or other things that could help make the case clear to those in leadership about the need for these investments? Thank you.
All right. Thank you, Alex. Next, we have Arthur Hanger, the past chair of FSMB.
Discussion, and we broke it down into looking at the barriers of the stigma that surrounds all this issue of burnout and how we seek care or don't seek care. And we came up with a number of ideas and issues that surround that, and how it not only surrounds the problem of the group ourselves that we were talking about, but as we looked at all the different groups here, how this issue around the stigma flows over into many of these other topics that we're just hearing about at this point. So some of the barriers that we talked about was first, we talked about the hidden curriculum and the impact that that has on the moral injury that occurs and how that affects the willingness of individuals to seek care, not only the physician, but all the healthcare workers that are involved in the whole system. We talked about the licensure and credentialing repercussions that come from the questions related to mental health. We talked about the fact that at a state licensing board level, this had been a huge problem. Steps are underway, and there's been some success at making some changes in that. But the problem is it also flows down into the credentialing committees of hospitals, insurance carriers, and others. And unless we involve all of those different parts of the system and make some changes to that, this stigma is going to tend to remain. We talked also about the fact that within state boards there's a responsibility of what's called duty to report that you may be aware of. And this also has a negative impact on the stigma of people being willing to approach somebody that they recognize as a problem or somebody that has a problem, that this barrier will be harder to fix because of the fact that it will require some legislative action in many cases to improve that situation. We also talked about, because of the cultures within systems, there's often a lack of information that's available or unwilling to share that across lines, which tends to slow down the chance of improving the situation. We talked about the fear of patients finding out about issues that a healthcare worker may have, and as a result, that creates a stigma that they're unwilling to address. We talked about the Press-Ganey scores and how they're used, and the fact that in many instances, some of that information that's obtained and shared can have a negative connotation for things moving forward. We also talked about the fact that when bad outcomes occur, often it leads to bad law. It also leads to awareness within the public, and it stresses groups that are being asked to affect change, hurts the stigma effect that comes from being unwilling to address it. So after we looked at all these barriers, we spent time talking about what can we do about this and what possible options are there. We talked about the fact that the ADA and the APA has very well outlined areas that speak to this whole issue around stigma questions and the impairment issue, and that this may be a step that will ultimately be taken by various legal means to use against hospitals and other systems that are using very intrusive questions as a way to try and change that, and other regulatory bodies needing to continue to look at this problem. We talked about research efforts that could go on. There's a wellness initiative that's going to go on in Chicago. We talked about a program where they have multiple hospitals where questions aren't asked and multiple hospitals where questions are, and beginning to look at those type of things to find how we can gain information that we can use to put pressure on driving those changes. We also talked about the fact that we have many premier institutions who have submitted commitment statements to the collaborative, and asked them to look at what they're doing now in terms of their questioning and see if they're actually doing what we suggest they ought to, and if not, to take a lead to make those changes on their impairment questions. We also thought that we should look at other international resources, such as the UK. We're going to have a talk tomorrow related to this, to see if we can't gain information from them and sharing that. We also talked about the fact that generational shift is going to be coming, which is going to have some unintended consequences, but that it may help as this younger generation comes forward to drive some of these changes. So those are some of the ways we thought we could deal with some of the barriers that we see. Thank you.
Thanks, Art. And last, let me introduce David Myers, who is the Chief Medical Officer of AHRQ, the Agency for Healthcare Research and Quality. And I just want to make a little note. He is speaking on behalf of the group. He's not speaking on behalf of his role in the federal government or himself.
Thank you. So why do you not want to have a researcher be the facilitator of a group discussion? My group now knows the answer to that, because we always have more questions and really don't want to get the group to consensus. So with forgiveness, we had 2 chief wellness officers, 2 NAM staff members, 2 association leaders, 2 researchers, and 2 feds in our group. So it was a really fascinating group discussion on this very bizarre topic of research. So after all of this is a big shift. And I'm very grateful that the consensus group recognized, and actually it came up again, that research is still part of the need moving forward. But as a recovering health services researcher, I have to ask you, why research? Research is expensive. It takes forever. You have to duplicate it to have any consensus, any faith in it. Why are we all interested in research for this topic? And I hope that for most of you, the answer is because we really want to know the right thing to do. We want evidence to help guide our decisions. Without a deeper understanding of the issues and the problems, we can't make change go in the direction we hope. Research allows us to predict and create change in the direction we want. So our group wrestled with that for a bit and then said, but who uses the research also drives it? The research question changes, or should change, based on the end user. The CEO looks at research. Well, actually, they often don't look at research. But if you can get it in front of them, they want to know what's the return on investment. How does this change my system? A chief wellness officer, and we had some in the room, said, I want to know what works, and where else it worked, and where it didn't work, and what's the context for making change. Patients, who are all here to serve, their question may be, what's the consequence of all this? What does clinician burnout mean to me and my loved ones? Which led us to our first main question, which is, given all of the potential questions out there and the limited resources and time we have, what are the priorities in research? Now, the NAM Action Collaborative already did an exercise and has a long list of what priorities could be or important topics, but we challenged the group and we really wrestled with this, and we came up that there are several different areas. Measurement is important, valid, reliable, easy to use measurement that work in multiple domains. That's still needed. The consequences of burnout were important to some people. Why should a CEO care? And they need that evidence. The drivers and the contributing factors and the contextual factors that affect burnout, and solutions to burnout on the system level. Those people who want to design interventions want this information so they can design purposefully. And then, as we talked about earlier, chief wellness officers want to know what works. What are the effects of different system interventions? So I'll let you all, in your own minds, think for a moment, if you had to prioritize, could you do that? In the end, our group sort of said no. It's like cancer. This is important. All of these questions are important. We need to move the entire field forward. That said, they recognize that this is a very particular moment. There is growing enthusiasm and understanding of the problem and people wanting to be engaged. And there's a fear among some that if in the next 3 to 5 years we don't make progress and aren't able to document our progress on this, that enthusiasm will move to other areas. And the progress we've made could sag back. And so the group, not in full consensus, but in general, came to the place that said the most important research we need to advocate for is on understanding the many natural experiments that are already happening and interventions and what works and what is the context among them. So then they turned to, well, who's going to fund that? And it was very reassuring for me to hear that the first answer people came up with is health systems are doing this. They're not only investing in doing the interventions, many of them are investing in understanding what works and testing it, and that's a great start. Then they turned to the associations, the AMA and the American Nurses Association, the AAMC. There are many society partners who care about this for their members, and they're willing partners to fund research. The feds are in this, and we're here in the room, and we've been part of the collaborative because we believe in this too. There are national foundations we can turn to. Because the issues are often local foundations are a source of partnership for funding, such as the Colorado Health Foundation or the California Health Foundation. And then people recognized also that EMR vendors, insurers, malpractice carriers also may be willing partners for this. And all of that led to a reinforcement of what the collaborative said, the consensus report said, which is that this should be moved forward. The research agenda should be a public-private partnership. That's the way to move this forward. Our group actually spent some time trying to figure out what those would be, and I'm not going to bore you with that part of it. So I'm going to move on and say, then they said, what's the primary goal? Going back to their priority, understanding what works for who and how and in what context. But if that information stays locally, we all lose. So that as we move forward this research agenda, there needs to be a dissemination part of that where we're sharing, where people are incentivized to share not only what worked, but what didn't work. And that context, and our NAM colleagues reminded us that the collaborative has already established the hub, the information hub, knowledge hub, which could be expanded to be a place where chief wellness officers and others in the field could turn to for information about what works. The geeks in the room then asked the question, who's going to do this work? Those were the researchers, and that's an important question that needs a little bit of attention. There was a lot of interest in making sure that as we move this research agenda forward, we pull from disciplines outside of medicine and nursing, that systems engineers, as the report itself showed, bring value to this, organizational psychologists, probably some psychiatrists too, public health, administration, educators, all have a role to play on the team. But when we talked about workforce, two other things emerged. One is the importance of teams, and that potentially helping systems study teams is a sub-priority in this, that teams need to be thought about researchers and implementers and clinicians together. The clinician teams need to be thought of as and studied more broadly, not just a clinician and a staff member, but the full range of people who today provide care in our system. And this led to a final challenge, which it's a little bit more esoteric, but I wanted to point out that we're going to experience a tension of those people who want to move into this field to make change and want to learn how to implement, and those people who want to study implementation. And those aren't always the same people, and if we assume they are, we're going to burn them out. So systems investing in implementation people as well as evaluation people is probably worth keeping in mind. Last 2 points, the group focused on methods. As a field, we need to hold ourselves to moving beyond anecdote. Anecdote absolutely is where one starts. It's our story, it's our experience, but we need more rigorous evaluations in these methods. That doesn't mean everything has to be a multi-site randomized controlled trial. There are methods that can be used, but we should demand better evidence as a field as we move forward. And finally, the group turned to, are there any models out there of how to move this research agenda forward, given all of those challenges? And we thought one that especially a NAM collaborative should look to is the patient safety movement. That started over 20 years ago with a NAM report that raised awareness. This field has a similar problem that we worry about how patients will perceive us telling the truth about what's happening, very similar to what happened in safety, and that internally the investment to improve safety comes out of somebody's hide and is always a struggle, and we saw that as similar here. But for us as in the research group, we thought this also is a model of how the country has moved forward in creating better evidence over time, creating public-private partnerships that involve the entire sector. And so that was our final recommendation to the group to consider.
Thank you, David. And just wanted to do a quick time check, if I might ask Charlie. It looks like we're a little ahead. What's our end time? 5? Okay, great. Well, we have a little bit more time for questions, so this is good. Are we able to project the poll everywhere question now? Okay, so while we talk and have sort of a live discussion, take a look at this question. And really, this is, I think, for us to sort of see. We've talked about all of the 6 different recommendations and pieces, but which one actually resonates the most as maybe, where you can commit to working on today? And go ahead and just text your answer in, and then we'll react after things go on. So if anyone does have a question, please come up to the mic, and I will go ahead and kind of kick it off to the group. There was something that Lois actually said when she was giving her group's update, and she was saying, I think we need to define what the optimal learning environment is. But the thing is, people are learning every day, and they've been learning for decades. So it leads us to think about this feeling of being overwhelmed. You read this consensus report and we're flying the plane, but we're trying to build the plane too. And so I wanted to toss out to the panelists, how would you react to a person that wants to work on well-being, but is just overwhelmed when they're taking in all this information and figuring out, okay, how do I execute, regardless of what type of stakeholder they are?
So I think you're talking about it's this massive issue, and it's not only complicated, but it's complex. But while that may be the challenge, it's also the opportunity. If you're interested in working on this, your work is necessary. There is a place for you to do it that aligns with your passion, and it's work that can really make a difference, not only to our learners, for example, but ultimately to patients and our healthcare system.
I guess that was a mic drop moment. Thank you. All right. So again, if you do have questions, please feel free to come up. And I'll toss another question out. So this is really thinking about the work of the Action Collaborative. And there's this exercise that I've done before for other projects called doing a premortem. So before we embark on actually executing on all these recommendations as a collaborative, just wanted to hear from the panelists, where do you think we might falter before we even embark on trying to realize these recommendations? Too early?
I would suggest there are a couple places we can falter. First, it can look like boiling the ocean, and so we don't do anything. Secondly, we cannot understand the very important we were told, there's 3 years to do this, and if we don't do something substantial, attention will turn elsewhere. I would argue we've got 3 years to do this. We can do something substantial. Attention is still going to be elsewhere. And so we better do it right and get it embedded and really do everything we can do to impact our environments and systems change in the time that we have.
I would say that your question is partially answered by what happens to the Action Collaborative activities after they sunset at the end of 2020. Because it takes a long time. We know it's going to take a long time. So where will this important activity or set of activities live? The Knowledge Hub, all the expertise in this room, et cetera.
Go ahead, David.
So I think the challenge is, we need to build some new infrastructure, and that needs to be sort of sustained over time. And there also needs to be, some work done by folks who are not currently funded to do that work, and also new partnerships with vendors and others. So I think that will require some sustained investment, and I think the National Academies has helped to raise awareness of the issue and started some of those discussions around partnerships. So that will be important to continue, but we'll need additional partners to make a more robust and sustained response.
So I think part of the reason that we're all here is because we really didn't take and do a good job taking care of ourselves up till this point. And now we're developing the opportunity to allow that to happen and create those steps. And if we don't move forward to do that, then we're all going to not take care of ourselves, and we'll all be doing the same things we've been doing before. So I think we have to really make a commitment to decide we're all important to one another and see that we work hard at that.
And I'll admit that I am worried and would not be surprised, but I hope we are able to overcome this, that the financial pressures on our healthcare delivery system are going to steamroll this burgeoning movement and may make it worse. And so if we cannot figure out how to make that link, and it's not just convincing people that this is the right thing to do, or that if we cannot make the link that creates change in the way we deliver care so that creating positive work environments happen, this could get worse.
Go ahead, Neil.
I think one other issue, I think that we need a systems approach to disseminating and implementing our systems approach, and including in that means developing metrics for success. How will we know that we've been successful? And that's a really important question.
Great point. Middle mic.
Thanks, everyone. David Baker, the Joint Commission. My question is about safety culture and the intersection of all of the work of the collaborative and safety culture. We still see organizations that frankly don't want to look at their problems. Employees, staff do not trust to bring forward problematic issues, whether that's either in their own health or whether that has to do with care processes. So my question for the group is, how does safety culture intersect with our work, and is that something that needs to be addressed simultaneously? And particularly, Art, as you're talking about trying to get clinicians to come forward, if they don't trust those people, then they're not going to come forward, and that's a significant barrier. David, you were talking about these different environments and what's going to work in different settings, and I would say nothing will work in an organization that has poor safety culture. You also mentioned about the learning that we need to do from the patient safety movement. So I think this is something for us to think about, how you can move forward organization safety culture, because I think that's going to be a fundamental barrier or facilitator of moving forward.
So, David, I'd love to respond to that, and it links into what I would have said as the answer to the previous question, is where we could falter, and I think we will falter if we don't make the very strong link between clinician well-being and the other aims that we're after, including safety, so that, as you know, if you care about patient safety, then you have to care about clinician well-being. In fact, it's my belief that the shortcut to a safer work environment is one that focuses on well-being. that's when you'll unleash all the professionalism that's needed for all those aspects of safety that may not be captured in performance measures, but are actually what matter to the outcome for the patient. So I think the good news is that safety and well-being are synergistic as opposed to opposite to each other, and that as with the patient safety movement, if we invest in well-being, we will see the return in quality outcomes, in other outcomes that we care about. I believe we'll see the return in financial outcomes as well.
Go ahead, David.
Yeah, David, thank you for bringing that. That's actually what gives me hope. But you're right, and Chris, I'm fully agreeing. The way to make this work is when we link the safety directly, those changes in well-being culture and safety culture. Sadly, in all of the progress we've made in safety culture, the one domain that almost has not moved at all are people feeling that they're in a psychologically safe space where they can talk about mistakes. And I have a feeling that's very much related to burnout.
Okay. Side mic.
Thank you. I didn't mean to cut in line. The other people were in front. All right. I'm sharing a comment received from my colleague, Bob McClellan at the Dartmouth Institute for Health Policy and Clinical Practice. The question is, there's been, we've seen in institutions sort of siloed approaches with safety and then well-being, return to work, employee assistance, EAP programs, workers' compensation, HR, which looks at benefits, autonomy, flexibility. And the report focuses on a chief wellness officer. How do we ensure that that is really pulling together all these different departments instead of creating a separate silo? Because it could be argued that right now there are already, people who are head of safety and health. And how do we make sure that it really is an integrated approach? I admit I'm coming from NIOSH, and our total work health approach really emphasizes this integrated approach. But we know it's extremely challenging and not easy to implement. And welcome your thoughts on that.
So I think it's critical to have an integrated approach as it relates to improving safety and quality, but also well-being, because you're thinking about, at the institutional level, a variety of things. First, of course, you have to measure to make sure that you have some comparison to your interventions. But you have to understand the process and engage in those currently managing the process, which could be the department or various other structures, as well as those interested in the function of those processes. And so integrative approach, I think, is critical to the efficiency of the efforts related to the chief wellness officer. A huge challenge for the chief wellness officer is the purview is huge. The clinical environment, the education environment, both at the graduate level and the undergraduate level. So depending on the system, it's a very, very big job. And I think it's another reason why the integration is going to be critical.
All right, go ahead.
Hi, Steve Singer from Accreditation Council for Continuing Medical Education. I thought this would be a great opportunity to share a Charles Mingus quote, actually. I'm going to make a point here, but Charles Mingus said that in his music, making the simple complicated is commonplace. Making the complicated simple, awesomely simple, that's creative. It seems to me from this discussion that with the consensus report, we've sort of outlined a lot of the information that we need, the strategies that we need. But what I'm wondering about is opportunities for the hard work of collaboration and harmonization, particularly in the creation of a leadership-led learning culture that could support this. And I know that each of you are reporting from your groups, but I'm interested to hear your perspectives about where there are opportunities for harmonization and that sort of creative work of collaboration in order to arrive at a learning culture in which well-being is a byproduct of that approach.
So I'm thinking about a parallel problem, which is sort of the learning health system. Which has taken sort of many years to go from that's recognition at the national academies, back at the Institute of Medicine actually when it was first discussed, into sort of efforts in systems to think about these topics within their strategic plans and their leadership culture and other issues. So I think there's a lot of development that we need to get to that space. The national academies and the ACGME and the AAMC is going to be hosting a meeting of leaders, CEOs, to sort of think about some of these issues in the coming month. So I think that will be critical to think about how do we get there. I'm not sure of the timeline, and I think the development is sometimes slow, unfortunately.
Lois, go ahead.
So I was trying to think through this question as well, and one example that I thought of was the learning environment and how accreditors think about it. So the LCME is focusing substantial attention on the learning environment through a standard, through expectations in the affiliation agreements between hospitals and their medical schools and the like. The ACGME has led us in terms of thinking about the clinical learning environment. And my question to myself is, how much conversation are we having across entities like that, where potentially there could be a greater understanding of what we mean by learning environment and attention? We know that medical education is oftentimes very siloed. So can we bring together some of the silos in these crucial areas to think about what these issues would be and make it a more, and maybe it is, but I am thinking, are there opportunities for integration and cohesion across that, but in a way that does not increase burden for people that already feel burdened by the accreditation experience?
Great, and we will come back to the first poll everywhere question, but there's a second question up. So if you have any thoughts about what additional feedback you have for the report out, please text it now. Side mic.
Hi, my name's Margaret Carey, and I teach a course called Hacking Happiness at the med school. Short version, it's not about the stuff. Secondly, as an executive and leadership coach and consultant, I just want to ask you a question. And to do that, because those of you in this room, I will not look, that I've coached will know that my job is often to ask the tough questions. And this is from Why We Still Kill Patients, Invisibility, Inertia, and Income. And thank you to the person who brought up patient safety, because that gave you the courage to come up here and say this. This is by Michael Millinson, Health Affairs blog, December 6th. I'm only going to read the first paragraph, and then I have a question for all of you. A recent front-page article in the New York Times conveyed grim news about patient safety. The first large-scale study of hospital safety in a decade concluded that care has not gotten significantly safer since the Institute of Medicine's 1999 estimate of up to 98,000 preventable deaths and 1 million preventable injuries annually. And since you compared this group and this study with the 1999 study, I want to ask, what can we do and what can you do so that this study doesn't go the way of the dinosaurs?
So I would just say it takes a long time, as we know, to change culture and practice. But one of the things that you need is sort of an infrastructure behind it. The National Academy of Medicine, for To Err Is Human and the quality reports that followed, continued to focus on this question and bring people together. I think the Action Collaborative, having formed before the study and continuing beyond the study, will help in this regard. And we're hoping to join in, more stakeholders to help us with this issue. But I think we've got, engagement of the EHR vendors, of folks involved in health systems, folks involved in education. So that's a big step forward. There's a lot of, information needed to, what do we do in terms of interventions and what's the evidence around those things and all the things discussed in the panel today. So I think the process is always, going to be a little bit challengingly slower than we would like, but we really need to have continued engagement. And I think the National Academy's effort, as well as all the medical societies in the room and others, other partners, the health systems and payers engaged in this discussion are a big step forward. So I think we're coming into it hopefully a little bit more robustly charged than the To Err Is Human.
So I would also say that there's a lot going on, and I know what's going on from the AMA's perspective, and just to give you a flavor of that, we have over 50 transformation modules available to all, not just to AMA members or physicians, that help with all the details of how to hold team meetings, how to have better leadership, how to do different aspects of workflow improvement, all of which will help to reduce burnout and improve the care environment for patients. And we have a recognition program that organizations can follow as a roadmap. So if they're interested in improving these issues, several people in the room have helped to create the components of that roadmap. And so I believe that by continually normalizing, measuring and responding to burnout, and to create these other structures that support organizations to continue to do that, this won't go the way of a nice report that's not thought of later. And I think there are lots of reasons why we can speculate that someone concludes that safety hasn't improved over that period of time. But almost always, if I'm visiting a place and there's a workflow issue that is impairing clinician well-being, it is also a patient safety hazard. And they're so tightly linked that I don't believe that we will be able to separate them. And so I think that this won't go the way of a good report that's not referred to.
So I think the way I would look at your question is, if you think about what's gone on with how we try and protect the public, state medical boards have cycled back and forth, and the result of some of what you talked about led to them becoming very onerous in the questions they asked and how they tried to go about in creating that protective umbrella for the public. Well, what happened was it really didn't work. It made physicians and other healthcare workers so that they wouldn't go and get help for themselves, and they tried to protect themselves against that bureaucratic structure. And so then what happened is now people have started to pull back and say, those questions don't solve the problem we're trying to fix. They actually become part of the problem. So what we're looking at here then is an attempt to try and say, this is a different way we need to go about trying to approach this, and trying to get people to take care of themselves, look after one another, and see if that will make a healthy workforce that then offers better protection to the patient. Hopefully that's going to be the outcome of this, and we will do a better job.
Go ahead, Jay. I'm sorry, David.
Just a small one. I'm wondering if this is also an opportunity, given much of the discussion, for the national academies to come together around this. I actually think maybe one of the ways to help move this report forward is to engage with the National Academy of Engineering and use this as a platform for bridging that divide that we talked about and bringing their expertise to the table, which is needed in safety, we already know and are doing, but might be a way to turbocharge this effort as well.
I just want to say thank you for those who have been posting comments to our poll everywhere. There's so much good, rich content in there, and I'll just toss it over to Jay for the next question.
So I hope that this is not an incorrect memory or inference, but a little history. 20 years ago, when the To Err Is Human came out, the headline was hospitals and doctors killing 100,000 patients a year. And I remember the response of my medical staff and the response of my specialty organization initial reaction was, we do not, right? It was a very defensive one. The headline, however, got everybody's attention and mobilized people. Now, I've seen the highlights from the consensus report come out, but I'm wondering if there isn't a simple something like doctors and hospitals are killing 100,000 patients a year, some kind of similar thing that will grab everybody's attention to say, whoa, what's that about? And I don't know that we've developed that yet. I'd be interested in your thoughts about that. But my memory is that it was the killing 100,000 patients a year that grabbed everybody's attention. And I don't know that we have that line out there right now. Just a thought.
So, Jay, we were on the messaging and communications working group before the reorganization of the Action Collaborative, and there was a robust discussion, which is, do you message a crisis or do you message something else? The crisis has the upside of mobilizing people, but has the downside of scaring people. And the opposite of a more gentler message. We opted for different messages to different groups, and I think it's time to rethink that messaging now that we have the consensus report out, we have more data. So the answer is I don't know, but I think that that's something that we need to think about while we're talking about implementing and disseminating this report.
And just I could say the message might be different for the public at large as compared to clinicians.
Absolutely.
All right, we're going to take one question that came in over the web. And this question, I think, probably stems from the fact that we do talk quite a bit about documentation in the EHR. And so the question is asking for reflections on a proposal for patients to be charting their own visits, not clinicians.
So I'd be happy to take a stab at that. I think we have to think about what's the purpose of clinical documentation. And then if we start with that, then who, what, and where on the documentation can follow. So if the purpose of clinical documentation is clinical communications, so that you know what the thinking was, what the story was, yourself the next time, or the colleague that will be picking up the thread of care will know that. That's important. I think it's been great that the 2021 E&M coding guidelines have changed, and so will emphasize medical decision-making over duration, time, and context-modifying factors of the presenting complaint or over the multi-system exam, so that we can get the documentation back to its core purpose, which is clinical care. I think it's also been very helpful that CMS clarified that documentation by a clinical assistant or by the patient does not need to be redocumented by the physician for it to count for billing. That also can reduce some of the sludge that's just put in the gears of our healthcare system. And so, do we want all patient documented history? I don't know. We want clear, concise history that's synthesized into a meaningful story and that is quick to pick up the next time you see that patient. And I'm not aware, I'm not confident that that would happen through a patient-only documentation. Just like I don't think we need a verbatim transcript of what happened in the hospital room or what happened in the exam room as our chart, because I think that would be very cumbersome in the long run, add to the cognitive workload, and make it very difficult for patient care to happen efficiently. So I don't object to there being some component of patient documentation, but I think it has to be done in the context of what is the goal of documentation.
Hi, John Ripp. I'm the Chief Wellness Officer at Mount Sinai in New York, and I've been reflecting on this on the consensus study and thinking about it in the context of your report outs, and I'm struck by, which I think a lot of us are experiencing, the enormity of this issue and the content and the potential directions that we can go. And so it's leaving me thinking and asking the question that I was asking myself on my way here today, this morning, what next, right? And I think that was a question that I believe each of the subgroups were asking. How can the National Academy, help facilitate? How can the Action Collaborative facilitate next steps? And I I wonder if it's worth examining. I'm not sure that those of you are the ones necessarily who can answer this most precisely. Maybe Victor can. But in the sense of the next steps to take, I wonder, is the National Academy poised in such a way to be able to focus on some of the elements of this report and help leverage for change more so than others? So have we asked ourselves, how can this group be most effective in utilizing elements of this report, perhaps as a way of narrowing and managing what can be seemingly overwhelming in terms of all the many ways we can go?
So Pascal and I are the co-leads of the implementation working group, and tomorrow we're going to discuss this with the steering committee. So those are the right questions. And stay tuned.
I want to note, though, that as some of the comments were running through, I was impressed that I can actually read them still. But as I was reading them, it reminded me, and I think it is important to state, that we are a largely socioeconomically privileged group. We are a largely minority group, and there are particular issues that underrepresented minority groups, women, socioeconomically disadvantaged parts of the health professions, for example, may well be experiencing. And it is very important that as we prioritize, we make sure that we are prioritizing on not just things that impact the largest number, maybe, but also some of the things that are just of the greatest importance. And so I think I would encourage the group to think about that and where we should be focusing our attention on some of that going forward as well.
Hey, Beverly Malone, CEO for the National League for Nursing. I follow up with my colleague because that was where my thinking was going, and I think he did a much better job of explaining it. But I was thinking usually when you're looking at transformation, you're thinking about it in a systems way, and you are thinking about it that way. You think about, okay, what outcome am I trying to get to at the supra level of the system? What outcome am I trying to get to at the system level? What outcome at the group level? What outcome at the individual level? And so my question is this report, at what level of the system should it be focused? And if so, then it would seem like you could work out the mechanisms to get you to the level of the system. For example, if you're going to a high level of the system, you would go with our colleagues in accreditation and in the work that would cut across all systems across the U.S. and maybe international. I've heard some words that there may be some international flyings in here. So you would work at a different level of the system. If you're going at the individual level of the system, you could do what Dr. David Satcher used to do. He used to hand out cards to people that he would meet. And they would ask him, how can I get in touch with you? And he would hand them out a get well card, stop smoking, have better sex. I mean, it would be just a card. I had never seen quite a card like that. But it depends on the level of the system that you believe we should be going at. And I'm not sure that we should attack all the levels of the system, and I would leave it to your wisdom to help us decide about that system level that needs to be first. So in a way, it's an audience kind of issue about what audience are we going to approach.
That was a great comment. I believe it's going to be discussed tomorrow at the steering committee meeting.
Excuse me, Daryl Kirch from the Association of American Medical Colleges. I've been struck by a lot of the expressed concerns about will this report just wither and fade away, or will it result in action? And I think we'll be well served to remember that the collaborative provided the framework for the study and the report,
And the collaborative actually started in a fairly opportunistic manner. So it was not the result of surveying the entire alphabet soup of organizations involved in medicine and other healthcare disciplines and the delivery of healthcare and government and so on. It basically was the letters in the alphabet soup that happened to be floating near the top at that time that came together. I think what this report now and the study has given us is a chance to go from being just opportunistic, who happens to be interested now, to being much more systematic and strategic in who needs to be engaged and how do they need to be engaged. While there are a lot of organizations out there, there are a limited number of people who focus on accreditation, for example. So that I think that the collaborative now has an opportunity to potentiate its work and really expand its work by, in a very thoughtful and systematic way, approaching these other organizations who probably have some interest in the topic, or at least have thought about it, but maybe have yet to be fully engaged. So I would encourage us to remain optimistic. I mean, even things that become accepted as, of course we needed to do that, like Medicaid. It took 18 years from the 1965 passage of the Act for every state to have a Medicaid program. You know, it will take some time, but I think the trajectory is very much in the right direction.
And I guess leading off of that optimistic note, actually, let me ask, was there any commentary on that? Okay. I think everyone wholeheartedly agrees. There was a question that came from the webcast, which was, how can national health professions accreditation organizations play a role? And I guess I would broaden that to say, what's the initial reaction from this group as to how we want to fold in all these other partners? And not, let it take 18 years to fold them in, but maybe let it take 6 months to fold them in.
So I'm not sure how to get all the potential partners folded in, but I'm thinking about ACP's publication from a year or two ago. Sue, I think you might have been part of that. And basically it was asking for an environmental impact statement from different stakeholders about policy or practice. And so what if we normalized the idea of having an environmental impact statement of your accreditation, your standard, your regulation, your policy, and a part of that was, what's the impact of that on the people doing the work? And we now have the ability to bring in a lot of data. We have the EHR timestamp data. We have industrial engineering expertise. So what if that became the standard? And we didn't just say around a conference table that it makes sense that only the doctor or only the APP can sign this, or that only this kind of professional can do that, or that this is a required step before XYZ happens, that we actually get some evidence behind it. And so we get evidence-based policy as the norm. We want evidence-based medicine. We adhere to that. We aspire to that. I think we need to aspire to evidence-based policies as well.
Each of the recommendations calls out certain stakeholders. There's obviously some repetition. They're all there. They're not named specifically, but the types of stakeholders. And then our job is to take from that list that's general categories and get the most important ones for each recommendation, target those as we move forward. So the first steps are already there in the report.
Chris, and just to add, Paul Tang had mentioned the click consequences of trying to put something new into the electronic health record or other types of regulations. What's the impact, or how do we measure the burnout impact of proposed changes?
I'm going to throw out one other sort of framework that I think would help us get rid of some of the sludge, reorient toward value. And one is sort of the click consequences or the environmental impact statement. But I've really been thinking a lot about how would healthcare look different if we prioritize relationships? How would training look different? How would episodes of hospital care look different? How would episodes of outpatient care look different? How would we relate to each other? How would the stability of pairings look different if we prioritized relationships? My hypothesis is, just like prioritizing clinician well-being is a shortcut to the rest of the quadruple aim, that prioritizing relationships is the shortcut to better outcomes, lower cost, better satisfaction. And so I would love to see us normalize that idea as well about it's not all transactional. It's not all housed in discrete data. A lot of the value that happens in our enterprise is based on relationships. And instead of turning a blind eye to that, I think if we directed our focus to that, we would come up with a better model of care.
That's a lot to chew on. That was a great comment, Chris.
Yeah, I'd like to respond to Beverly's comment, sort of asking us where in the hierarchy of need we should spend our resources. I actually think that we have to do it at all levels simultaneously. And I think we have to be careful that we don't create barriers to success at the local level by acting too extensively at the higher levels. Let me give you an example. We can create in graduate medical, we have created in graduate medical education standards around well-being infrastructure. For instance, the requirement to have mental health care capabilities 24/7 for residents, and that they must have access to it and they must be able to access it. It's now a written standard. We're holding people accountable. It became effective July 1st. These are sort of foundational standards, but it doesn't say how an institution has to meet the standard. It doesn't say who has to be that person. We need to provide the field with the flexibility to create locally successful options. And then the research needs to harvest those options. So my response would be we need to respond across the entire spectrum, and we have the entire spectrum in this room and in the bigger room when we bring everybody together. We have national organizations, we have individual institutions, we have trainees, we have senior leadership, we have accreditors, we have licensors. We have the ability to attack the system at all of the levels. And in response to another question, if we don't do something within the next 3 years, something else is going to happen. It's not just going to get dropped. I think that there is pressure on us to be successful. And we can all speculate about what the other options are, but if the profession doesn't own this and fix it, someone else will, and they will likely not fix it the way that we would like it fixed. So I think we have our work cut out for us, and we have a roadmap, and I think we need to start spinning the wheel with everybody pushing at their level and coordinate that activity through this effort, through this body.
Can I just build on Tom's point in Hellenberst? I was trying to think about how to frame this from the Council of Medical Specialty Societies. It would be great to see all the recommendations that came out of all the work groups today stratified by what are things we can do soon, what'll take a little bit longer, and what are really the longer term plans, because I couldn't agree more with Tom. I think if anything, what we're seeing in terms of the pushes on clinicians around efficiency, the growth of private equity, we're really beginning to see the squeeze getting tighter. And I think it's less that somebody else will come in, or I think it's more so that the crisis will just get worse. So I'd love to see us take, really identify a series of 5 actions we can take this year that we can just push out front and say, this is what the NAM's been doing, this is where the collaborative is really adding value. For example, the paper that came out saying, here are the right tools to use. Just start using these. Can we create some opportunities? I was thinking, David, of our earlier work at ARC on practice-based research networks. Can we think about really some system-based research networks to begin sharing what they're learning, really just get out there and put that information out there as soon as possible, because I think the crisis is really just beginning to percolate. I don't think it's done.
That's a great point about trying to create a sense of urgency now that we actually have sort of a phenomenal foundation to build off of.
Carol Bernstein, Albert Einstein College of Medicine. And again, I want to piggyback on the last two comments, great wisdom in the room. We can all do things when we go back. And I just want to echo the wish, because I was frantically taking pictures, Chris, in our group. I think that the work groups this afternoon came up with ideas. I think everybody in this room has a place at somewhere in their organization, in their association, that they can take just those things. And I'm thinking already about a meeting next week that I'm going to go to at Einstein that happens to be a steering committee on this. I'm thinking, wow, I have some ideas here. It's not the perfect. Remember, the perfect is the enemy of the good. It's just a place to start. And I agree with Tom so much that this is every level. It's not just in the C-suite. We have to get to the bottom. And any place you can start in your organization or continue, given that I think many of us have already started, is going to be helpful. And that we all have a responsibility in this room to take this home. So thank you.
Great point. And I think I want to close by bringing up the first poll everywhere question we had. And the question was, I'm not sure if we can project it, but essentially it was, which out of the 6 recommendations is really hitting home right now, that one that you want to really start using? And creating positive work environments really rose to the top at 41%. Wanted to get some final reflections on the group, and not to demean the others that weren't part of creating positive work environments, but what does that mean? What does this data mean to us? Does it mean we want to maybe spread out the creating positive work environments and use that lens for all of our other work streams? Or is this surprising, or is this what we'd expect?
I'll jump in first. I actually think this is what the research group did. When we tried to prioritize where the research was most needed, the thing that rose to the top in our small group was, how do you create positive work environments? They want the practical tools. So I actually think there's echo that it's not an either or among these 6. It's an and.
I think that if you're a clinician and you're working, you want a positive work environment. You look at 19%, if you're a learner, you want a positive learning environment. I think those are the ones that are sort of closest to your experience, so I think it makes perfect sense. You could have probably predicted this by looking at the people who signed up for the breakout groups. So this makes absolute intuitive sense. And also you'll notice that the ranking is roughly in the order that we placed the recommendations, except for E. It sort of follows from everything that we did that it made the most sense, basically.
As we understood it in our group, there were very practical reasons for splitting learning environment and work environment. But in fact, ideally, our work environment is a learning environment. And let's face it, our learners do a lot of work. So I would suggest that we're really, if you look at that and you look at stigma, I think part of the message is this is a people issue. These are the people that are working, the people that are learning, the people who may be experiencing stigma. And the other things on that list, as important as they are tools and things that need to be harnessed for people. So that's how I see those numbers.
Well, with that, we'll close our session. I want to say thank you to the panelists for reporting out and giving pretty amazing insights, and thanks for great questions from the audience.